lecture today is about the anterior abdominal wall. First of all, we will study the layers of the anterior abdominal wall. From superficial to deep, the layers of the anterior abdominal wall, first of all, is the skin, superficial fascia, which consists from two layers, outer fatty layer and inner membranous layer, layer of muscle. Next, we have a layer of fascia, which is called transversalis fascia, extraperitoneal fat, and lastly is the parietal peritoneum that line the anterior abdominal wall. First, the skin. What are the features of the skin of the anterior abdominal wall? The skin of the anterior abdominal wall is loosely attached to the underlying structures, except at the area of the umbilicus where it is tethered to the scar tissue. Otherwise, it is loosely attached to the underlying structures, except at the umbilicus, it is firmly attached to the linea alba. The umbilicus, or another name, is the navel or belly button, is a scar representing the site of the attachment of the umbilical cord. This is the umbilical cord extending from the placenta toward the anterior abdominal wall. So the site of the attachment of the umbilical cord to the anterior abdominal wall in the fetus is the umbilicus. It is situated in the linea alba at the midline. What are the lines of cleavage of the skin? Another name to this line is the Langer's line, are constant and run downward and forward, downward and forward, almost horizontally in the trunk. The next layer next to the skin is the superficial fascia. Superficial fascia, as we said before, consists from two layers. Superficial fatty layer, the fascia of Camper, continuous with the superficial fat over the rest of the body and may be extremely thick and may reach to about 8 centimeters. And this is a fatty layer. It's continuous with the fat all over the body. Next to the superficial fatty layer is the deep membranous layer, or called scarpus fascia. It is thin and fades out laterally and above, where it becomes continuous with the superficial fascia of the back and the thorax, respectively. We can see that the anterior abdominal wall is devoid of deep fascia, just superficial fascia that consists from two layers: superficial fatty layer, called fascia of Camper, and the deep membranous layer called scarpus fascia. This is the skin and this is the superficial fascia. This is the fatty layer, which is yellow in color, and deep to it here in light blue color is the superficial fascia or the membranous layer. It's called scarpus fascia. This superficial layer اللي هي fatty layer or Camper's fascia is continuous with the fat that is covering the chest or that is covering the lower limb. It's continuous with them and it's may be thick and may reach to up to 8 centimeter thickness. This is the fatty layer. Next to it is the deep membrane or membranous layer or the scarpus fascia. This layer just at the root of the lower limb, one finger breadth below the inguinal ligament, it will be attached with the deep fascia. It is tethered to the deep fascia. So this is the line of the fusion just below the inguinal ligament, line of fusion of the membranous layer with that of the fascia lata, with the deep fascia of the lower limb. At the midline, it is continuous. It is not attached to the pubic bone. It is continuous with the deep fascia of the penis or the clitoris. We can see here, this is the fatty layer, and this is the membranous layer. The membranous layer will be continuous, will form a tubular sheath around the penis, and also it will become continuous with the fascia of the scrotum. Next, it will become continuous in the perineum as what we call the Colles fascia. Colles fascia will be attached to the perineal membrane, This is the membranous layer. Next, as we said, we didn't have deep fascia in the anterior abdominal wall because deep fascia is a thick layer of fibrous tissue that will restrict the movement, that will restrict the expansion of the abdomen. Instead, we will have another arrangement of the muscle, as we will see. Muscle of the anterior abdominal wall, we have a 3 thin sheet muscle, which is called the oblique muscle, the external oblique muscle. This is the outer one. Then next to it is another thin sheet muscle called internal oblique, and next to it is the transversus abdominis muscle. Why we call it oblique? Because the direction of the fiber is run obliquely, that of the external oblique run downward and forward, that of the internal oblique upward and forward at right angle to that of the external oblique, and transversus abdominis, from its name, its fiber will run horizontally. This muscle laterally is fleshy, and medially it will become aponeurotic. It will become aponeurosis, and it will be inserted at the midline into the linea alba. Laterally it is fleshy, and medially it is aponeurotic. Its aponeurosis will form what we call the rectus sheath. This rectus sheath will envelop the rectus abdominis muscle. These are the muscle, and we can see here that this is the external oblique originating from the lower 8 ribs, running downward and forward until it is inserted at the midline to the xiphoid process into the linea alba. And this is just deep to it is the internal oblique. Its fiber run at right angle to that of the external oblique. It originates posteriorly from the thoracolumbar fascia, from the iliac crest, and from the inguinal ligament, and its insertion, it's here. And this is the transversus abdominis muscle, and its fiber we can see here is running transversely. This is the external oblique muscle, and we can see how medially it become aponeurotic, and it is inserted into the linea alba. Its lower end will be rolled. It will be rolled under، يعني راح تلتف على نفسها. Its posterior border is free, is not attached. This is the external oblique. Its posterior border is free, and it will form an angle that is called lumbar triangle. This lumbar triangle is formed by this muscle, which is called latissimus dorsi, upper border of the iliac crest, and the posterior border of the external oblique. Lower down and medially in the aponeurosis of the external oblique, we have a triangular defect that is called superficial inguinal ring. From this superficial inguinal ring, the spermatic cord will exit. So the superficial inguinal ring, it is a defect in the aponeurosis of the external oblique. This is the inguinal ligament, as we said before. It is the lower edge folded edge of the external oblique, and it extends from the anterior superior spine to the pubic tubercle. This is the inguinal ligament. It forms the floor of the inguinal canal. Posteriorly, from its medial end, we have another ligament attached called lacunar ligament. So this is the inguinal ligament extending from the anterior superior spine to the pubic tubercle. This is a muscle here سميناها rectus abdominis muscle, or the six packs. Another name is the six packs, extending from the pubic bone, and it is inserted into the fifth, sixth, and seventh rib. Lie on both sides of the linea alba, and it is divided by these tendon, dividing the muscle into parts. These tendons called tendinous intersections. Now we come to the blood supply of the anterior abdominal wall. Blood supply of the anterior abdominal wall is provided by the superior epigastric artery, which is regarded as a continuation of the internal thoracic artery. Superior epigastric artery. Inferior epigastric artery, which is a branch of the external iliac artery. And it anastomoses with the superior epigastric artery within the rectus sheath at the level of the umbilicus. This is near the midline. These arteries supply the anterior abdominal wall near the midline. Another arteries that supply the anterior abdominal wall from lateral side is the intercostal arteries, the lower two intercostal arteries, and the four lumbar arteries, which originate from the abdominal aorta. Lumbar arteries originate from the lumbar aorta. Another artery is called the deep circumflex iliac artery. Which originated from the external iliac artery and run upward and laterally parallel to the inguinal ligament and supplying lower lateral part of the anterior abdominal wall to reach to the anterior superior iliac spine. So these are the arteries that supply the anterior abdominal wall. Another arteries that runs superficially, that originate from this femoral artery. This femoral artery is the continuation of the external iliac below the inguinal ligament. From this femoral artery, we have superficial arteries that also supply the inguinal region. Near the anterior abdominal wall is called the superficial circumflex iliac artery, superficial epigastric artery, and superficial external pudendal artery. These arteries are superficial and supply the anterior abdominal wall near the inguinal region. Another important note about the inferior epigastric artery, as we said before, it originates from the external iliac artery and it runs medial to the deep inguinal ring. This is the deep inguinal ring. It runs medial to it and runs upward to supply the anterior abdominal wall. We have an important item that is called Hesselbach or inguinal triangle or Hesselbach triangle. This triangle is bounded. What is superior or lateral border is by the inferior epigastric artery or vessel. What is its medial border is by the lateral edge of the rectus abdominis muscle. And its inferolateral border is by the inguinal ligament. This triangle is called Hesselbach triangle or inguinal triangle is important clinically. Why? Because the most direct inguinal hernia يعني أكثر أنواع الفتق المغبني المباشر راح يكون في هذه المنطقة. Most direct inguinal hernia and the external supraphysical inguinal hernia occur in this area. So it is important to know the boundaries of this triangle. What is the venous drainage of the anterior abdominal wall? As we can see here, this is the anterior abdominal wall. We have the upper part and the lower part. The upper part, mostly it will be drained into this vein, which is the axillary vein. And the lower part will be drained into this one, which is the femoral vein. Also, there is a connection between the superficial veins here near the umbilicus with the veins that go deep to the liver. So the venous drainage mainly here, above mainly into the axillary vein, upward and laterally to the axillary vein via the lateral thoracic vein, while below into the femoral vein, via the superficial epigastric vein and the great saphenous vein. Also, there is a connection through the umbilicus with veins that go through the ligamentum teres to the liver. Here you can see this is the umbilicus. Embryologically, the umbilicus, we have two arteries that pass through it, one vein and two arteries. The vein will pass up to the liver, and the two arteries will pass below to the common iliac vein, to the common iliac arteries. So there is a connection in between the systemic vein and the portal circulation through ligamentum teres, If there is a problem in the liver, if there is a venous congestion or there is a problem in the liver, here the vein will be congested, the veins will be congested and will be engorged, and it will appear on the anterior abdominal wall just like this. This is a varicose vein of the paraumbilical veins that is called Caput Medusae. Lymphatic drainage of the anterior abdominal wall. We can regard that the umbilicus is a landmark for the blood supply and for the lymphatic drainage. In the lymphatic drainage, the area of the anterior abdominal wall above the umbilicus will drain into the anterior axillary lymph node that originate or that is localized near to the pectoralis muscle, while that below the umbilicus will be drained to the superficial inguinal lymph node. Posteriorly, the iliac crest, the area above the iliac crest will drain to the posterior axillary lymph node, while that inferior to the iliac crest it will drain to the superficial inguinal lymph nodes. What is the nerve supply to the anterior abdominal wall? It is derived from the lower 6th thoracic nerve and the first lumbar nerve. Lower 6th thoracic nerve, that is T7, 8, 9, 10, 11, 12, and L1. We can see here that the T7 is at the level of the xiphoid process in the epigastric region. T8, 9, 10, T10 is at the level of the umbilicus. T11, 12, and the L1 just in the inguinal region, just above the inguinal ligament and symphysis pubis. So, from the lower 6th thoracic nerve and the first lumbar nerve. This nerve will supply from the full thickness of the anterior abdominal wall from the skin, fascia, muscle, and the parietal peritoneum. This nerve will run in between the innermost, that is the transversus abdominis muscle, and the internal oblique muscle. These nerves will pass through the posterior wall of the rectus sheath. These are the anterior rami of this nerve. It will pass through the posterior wall, and then it will supply the rectus abdominis muscle and pierce it to emerge on the anterior surface of the rectus sheath to supply skin. All the lower 6th thoracic nerve will pass through the posterior wall of the rectus sheath, and it is one of the content of the sheath, while that of the lumbar nerve will do not pass through the rectus sheath. Instead, this nerve اللي هو L1 consists from two nerves, which is the iliohypogastric and the ilioinguinal. Iliohypogastric and ilioinguinal. Iliohypogastric will emerge just above the superficial inguinal ring, while that of the ilioinguinal will pass through the superficial inguinal ring. These are the skin areas involved in referred visceral pain. This is a referred visceral pain. Referred visceral pain, we can see that the pain from the appendix here, for example, is first felt by the patient in the umbilical region, and we can appreciate that the appendix is lying in the right iliac region, So why the patient feels the pain is in the umbilicus while the appendix is located in the right iliac region? This is because the appendix is embryologically regarded as a part of the midgut, and the midgut embryologically lies at the midline. So this is one of the explanations that the patient feel the pain of that's originated from the appendicitis, so that is inflammation of the appendix, at first near the umbilicus. Then it will shift to the right iliac region or right iliac fossa. The last part of our lecture is the rectal sheath. As we said before, these three thin sheet muscle, it is fleshy laterally, and medially it will become aponeurotic. This aponeurosis medially, it will form the rectal sheath. The rectal sheath, according to the level, it will consist from different layers. First of all is a fibrous sheath that is formed mainly by the aponeurosis of the lateral abdominal muscle. It encloses the rectus abdominis muscle and pyramidalis muscle if it is present. What it contains: anterior rami of the lower 6th thoracic nerve, superior and inferior epigastric vessels, and the lymph vessels. This is the rectal sheath in the normal cadaver. After removal of its anterior wall, we can see this is the rectus abdominis muscle. What is the content? We can see here. This is the rectus abdominis muscle. These are the lower 6 thoracic nerves. And these are the arteries: superior epigastric artery, inferior epigastric artery, and these are the nerves. The lower 6 thoracic nerve with its muscle, with the muscle, rectus abdominis muscle. And what is the rectus sheath consist from? According to the level. What are the layers of the anterior wall? What are the layers of the posterior wall? According to the level. Above the costal margin, the rectus sheath anteriorly is formed by the aponeurosis of the external oblique anteriorly, and posteriorly it consists from the 5th, 6th, and 7th costal cartilage with their intercostal muscle. Between the costal margin and the level of anterior superior spine, the aponeurosis of internal oblique will split. Part of it will go anterior with that of the external oblique, and part of it will go posterior with that aponeurosis of the transversus abdominis to form an anterior wall and posterior wall of the rectus sheath to envelop the rectus abdominis muscle. Medially, the aponeurosis of both sides will unite to form the linea alba. What is below, and between the level of below the anterior superior spine until we reach to the pubis or pubic symphysis, and the pubis, the 3 layers of the aponeurosis will pass anterior, and that of the external oblique, internal oblique, and transverse abdominis, all of them will become anterior, and then we have no posterior rectus sheath, no posterior wall of rectus sheath. Just the rectus abdominis muscle will lie directly on fascia transversalis. The muscle here will lie directly on fascia transversalis, and the posterior wall of rectus sheath will end by a line called arcuate line. So this is the anterior superior spine. هنا عندنا ال posterior wall of rectus sheath will end by يعني curved line called arcuate line, and the rectus abdominis muscle will lie directly on transversalis fascia. This picture represents the rectus sheath above arcuate line, and we can see how the aponeurosis of internal oblique is splitted in two layers, one that go anterior and one that go posterior. This one go anterior with that of the aponeurosis of external oblique to form the anterior wall of rectus sheath, and one that pass posterior with that of the transversus abdominis aponeurosis to form the posterior wall of rectus sheath to envelop the rectus abdominis muscle, and the aponeurosis of both sides, right and left, will unite at the midline to form the linea alba. While below the anterior superior spine, the three layers of aponeurosis will become anterior to the rectus abdominis muscle, and the posterior wall of rectus sheath will end as arcuate line. Here we can see that the rectus abdominis muscle is lying directly on the transversalis fascia. Thank you.